Hello, everyone, and welcome to our cardiovascular imaging conference from the DeBakey Heart and Vascular Center. I'm Dr. William Zoghbi, Chair of Cardiology here, and it's a pleasure to welcome you to our new year, 2025, starting with a conference on contrast echocardiography, or you can call it ultrasound enhancing agents. Actually, you could use these terminologies interchangeably. And we will talk about technique, impact, and on clinical management, diagnosis, and also some of the issues lately that have been raised regarding safety. And actually, there's just a new publication regarding that, which alleviates concerns, I think, overall. All right. So when we talk about contrast, probably even before the agents that are much smaller that cross the pulmonary circulation, often we use, and we still do, agitated saline. Interestingly enough, if you agitate saline even without putting any air, you have microbubbles that are formed, and they could be in the order from 5 to 10 microns or more. And these tiny microbubbles have an interesting effect when they interact with ultrasound. They reflect the sound, and that's why it becomes white when you inject it. And one of the properties is for us to detect shunting, right to left shunting. And the reason for it is, since these microbubbles are large and they are microcavitations, mostly of air, they get absorbed in the pulmonary circulation. They're large also enough. So when they go in the pulmonary circulation, they should not cross to the left side. So we take this property and detect shunting in this situation, detect shunting at the interatrial side, right, through the atrial septum, and that you could see here, the interatrial septum is bulging to the left, and with it comes contrast to the side, and that's a patent foraminovalle. You could have that in atrial septal defect. And remember, for you to be able to detect that transient higher pressure between the right atrium, left atrium, that's what causes it. So usually it's a transient, as opposed to the AV fistulas that occur in the pulmonary circulation. They're not dependent on pressure gradients, so they will take time, 5 to 6, 7 cardiac cycles to cross in the pulmonary circulation and go to the left side for you to be able to see them. And they gradually build, as opposed to a periodic puff of contrast that you see, just like in this situation here. So we usually, when you inject like this, you agitate the saline or any other solution if you want, but saline is fine, and then you inject that, and you don't have to put air. And if you're gonna need to put air to cause these micro, it will be really to the tip of that that syringe, just a very tiny tip. And if you have a lot of contrast, you don't need to keep injecting, because remember, these go to the systemic circulation, to the brain, other things, so you prefer not to have large microbubbles going once you have a diagnosis already set. And we also use it, although you may have tiny tricuspid regurgitation, you enhance this tiny tricuspid regurgitation jet, and you'll be able to get a signal by Doppler, by continuous wave Doppler, just like you see here. It's contrast-enhanced tricuspid regurgitation. That is very helpful when you want to estimate what the pulmonary artery systolic pressure. So although you may not see TR per se, you can still inject it, and the yield is quite decent because you enhance that. Because the yield becomes so decent, putting color Doppler on a contrast image is just, number one, not too appealing, because you'll see color Doppler almost everywhere. You will over-enhance if there is a regurgitation, so this is not what you're going to use contrast or ultrasound enhancing agents for. So CW, enhancement, shunting with saline, etc., and then obviously you can use the newer agents to enhance any jet that you want to talk about. So the factors that affect bubble robustness mean how long do they last, is arterial pressure, right? So if you're in the left circulation, the early Albunex compound did not last very much in the circulation, and in every systole the contrast will be less. You don't have to worry about that because the newer agents are much more resistant. Two is they have a shell, and that shell could have different composition, and inside can be any gas, air, where you're not adding gas or you're not manufacturing these microbubbles, and high molecular weight inert gas in the manufactured second generation, I would call them, microbubbles. And this is what's available in the United States, Optison, Definity, and Lumason. And they're pretty much available in almost any country nowadays. They're quite affordable, I think, but you have to decide when to use them to enhance image on the left side of the heart. So the difference about these, as opposed to agitated saline, is that they are tiny. You could see that the size is between 1.5 micron to about 3 or 4 micron. They're very small. They cross the pulmonary circulation. The shell composition is similar in Definity and Lumason, which has a lipid monolayer as opposed to a denatured albumin. You could see what the gases are, high molecular weight gas. In green are agents that were developed and not available in the United States at this time. Levofist is available in Europe. Okay. What's the major advantage of these ultrasound enhancing agents? The major advantage is they cross to the left side, and therefore the promise of enhancement of the image if they are very difficult. So obviously you can't interpret this image on the left side from the apical window, and if you use contrast, you can enhance it, and you can interpret it and measure size of the ventricle, function, regional function, global function, etc. And the current indications, as we will see, is if I can't see, maybe 2 segments or more, it will enhance my diagnostic accuracy and hopefully also alter my management down the line. Interestingly enough, these agents now are also interact with your ultrasound, beam and the properties of the ultrasound that you send, right? Remember from the first lectures that we had, and if you're online, we've talked about the basics of ultrasound, is you send packets of high frequency sound, and this packet's gonna interact with the bubble itself, and the bubbles themselves, they're gonna reflect ultrasound back. And but if you have too much of them, they're gonna reflect a lot that will attenuate the ultrasound that is behind it. So I'm gonna give you a first example here of attenuation, we call it attenuation, of a large and rapid bolus of injection. So if you draw the ultrasound agent, contrast agent, and inject it fast without any dilution, at the beginning you may see some contrast, and after a while you're gonna see probably a lot that it will hinder seeing beyond it. Okay? So let's take a look at this. Another thing that you're gonna notice is when I inject on the right side, this is the right ventricle here, you're gonna see a sliver of contrast. And that sliver is because the ultrasound beam is emanating from the transducer. The first thing is gonna hit is at this angle, it's gonna hit this contrast agents here. They will be so strong that you're not gonna see in the right ventricle. So you're gonna see a sliver of it. If you wait for it to dilute, then you're gonna start seeing the right ventricle itself. So notice now, here, I'm gonna play it. Contrast is being injected on the right side. The only thing I see on the RV is a sliver. I'm start seeing it in the left ventricle. Notice what's gonna happen because the concentration is very high. You have attenuation behind it, below it, and the only thing that you see is the tip of the ventricle. So this is not poor contrast. This is too much contrast because I'm attenuating. It's also almost like you're imaging metal or calcium. You're reflecting all that, and you're having quite a bit of attenuation behind it. As opposed to having too little of a contrast, you'll see sparkles or not too high of a concentration. Certainly you can see all the way through, all the way, let's say, from the apex to the atrium, okay? So, in contrast, and in general, we didn't, before contrast utilization, we did not think of the mechanical index. The mechanical index is basically how powerful is the ultrasound beam being sent and being sent to the body for you to image it. It is peak negative pressure. So this is the pressure here, how the peak divided by the square root of the frequency of the beam itself. Now, so this is, this wave, if you have a higher pressure, the magnitude of this wave would be larger, both ways, positive as well as negative. So just imagine if you're sending a high energy that is compressing. If you compress the bubble, then nothing is going to happen to it. But if you pull it apart, basically with so much high negative pressure, you're going to break the layer of the microbubble. So now we're talking about it as if we're talking about, a long time. We're talking about microseconds here, milliseconds, right? So whenever you image, therefore, with a high mechanical index, you're going to destroy quite a few of these bubbles. And you need to know, as a clinician, sonographer, a clinician, need to know when are you destroying, quite a few of these microbubbles. And what do we talk about a high mechanical index? The index is close to 1. So from 1 to 1.5, still very safe to use, high pressures, etc. This is called high power. Low power is, or low mechanical index is like 0.3, 0.2, even 0.1. Okay, so the range is not huge, but you need to know that because the display on your screen of the ultrasound machine will have that mechanical index. Nowadays, most of these machines are programmed. If I want contrast, it will go down to a lower mechanical index, so it's not destroying as much. If I want regular imaging, the mechanical index is high. Why? Because you have good power and at the same time you can image. Well, if you image regularly with a very low mechanical index, you're not going to see much of the myocardium per se, but once contrast comes in, you'll preserve it and you'll see it very nicely. Okay? Now, here, this is the effect of a mechanical index change on the intensity and duration of contrast, okay? So one thing we're going to do here is change, this is the mechanical index, it's a little blurry, 1.5 or so, and we're going to gradually decrease it. And you'll see what happens to the contrast per se here. Very high contrast, you see it's almost like a hurricane heart. I'm going to gradually come down on it, and you'll see the preservation of contrast, and you don't see this hurricane-like situation. And the reason why you saw a hurricane-like situation is that the new contrast is coming, and while it's coming, you're destroying it with your ultrasound beam, so you have fresh in addition to destroyed contrast, right? So here you go, it's high again. See, the opacification is not really as good. I'm going to decrease it gradually, and nice duration of contrast, and you could see it in diastole and systole without this mixture of black and white and a hurricane-like heart, okay? So nowadays, as I said, usually there is a setup for contrast to bring down the mechanical index, and you don't have to worry about it. But you need to know, as an interpreter, if somebody forgot to use the contrast setting, and if you see a hurricane-like heart, right, you have to think that somebody is still using a high mechanical index. There's another, I don't have a case for you, but there's another possibility for you to have that, is if you have a huge ventricle with a big apical aneurysm, where you have stagnation of contrast when it comes in. No matter what you do, this contrast that is in the apex that is not leaving the apex is bombarded. So the base will look good, but the apex doesn't look as good, right? So you try to play to decrease the index as much as you can, inject a little more contrast, particularly if you're looking for a thrombus in that apex and you want to try to visualize it as much as possible. Well, in ultrasound, we also talk about harmonic imaging, right? We talked about that in the basics of ultrasound. I think this is very important because, you know, harmonic imaging was developed early on for contrast. Why? Because interestingly enough, if you hit these micro bubbles with ultrasound, they will vibrate. And with their vibration, they will emit the similar fundamental frequency that you are imaging. If I'm imaging at 3.5 megahertz, it will emit the 3.5, but interestingly enough, it may emit a double or 3 times that frequency. It's almost like you're hitting if you play an instrument, a string instrument, be it a piano or a guitar, if you hit it very hard, it will emit more than this fundamental frequency of the string itself. It will have other intonation. The same thing with microbubbles. So early on, we said, if I want to enhance my microbubble visualization, I'm going to need harmonic imaging because it will intensify the signal from contrast compared to the myocardium, the valves, et cetera, et cetera. And actually, that's what was found. But the interesting thing that was found also is that harmonic imaging is also good for imaging of the cardiac structures without ultrasound because there is some vibration. I mean, initially you thought it's not going to vibrate as much, but there is some vibration which leads to a clearer image and taking away, you know, artifacts that you may see, particularly in the apex. Okay? So let's take an example here. On this, there's a 3.5 megahertz, and there will be an H before, which is harmonic imaging 3.5. Remember, if it is harmonic imaging 3.5, what you're sending is half of the 3.5, and you're listening at 3.5. Okay? So let's see. Since now it's still picture without harmonic, notice that contrast is there already. You cannot even tell the difference between the myocardium, you barely can tell it. This is an apical 4-chamber view, and contrast here. They all blend. They're almost the same, okay? So basically, you're not enhancing the contrast portion, and you're not really using contrast for its best advantage. And if I turn on H, you will see within just instantaneously, the image is different. Okay, let's play it. H is on. And H is off. All right? On, off, basically. Which tells you that for you to be able to see the best contrast and take advantage of this vibration, excessive vibration of the microbubbles, you have to use harmonic imaging. Again, interesting enough, nowadays we use harmonic imaging in almost anything, so you don't have to turn it on and off, but it is optimized for contrast usually for you to be able to see that. Got it? Okay, these are the major principles. As opposed to contrast in the catheterization laboratory, right, where you don't really interfere, you know, the setting of your image intensifier and how much radiation, you're just not interfering with what you see. It may enhance the overall seeing. But here, you have to understand how it works, meaning that the imaging settings on the ultrasound machine will influence what you're going to see, and also will influence how much you contrast, how fast you inject contrast. You want to make sure you don't attenuate it. So I'm spending enough time here because this is the crux of what you see in a clinical laboratory, is how do you use contrast to optimize, you know, image viewing. So its applications, the one on the left is the one that is approved by the FDA, and the others are basically you could use them offline, whatever it is that you're going to use them. But number one is it was developed for endocardial border definition. So all these agents, the three agents that we have, you inject them on the right side, they go across, come to the left side, and enhance your border, particularly when you're not seeing for regional, global ventricular function, et cetera. Enhancement of Doppler signals, you take advantage. We talked about don't use it for color Doppler. You can use it for CW and pulse because it will just make it too much for you to interpret or use clinically. So, but it will enhance your Doppler signals. Myocardial perfusion, not an indication at this time. You could use it, while interpreting something, if you will. Still a lot of research used in the research laboratories, therapeutic, all experimental, okay? So probably the most recent guideline is, 7 years old now or something like this. First author, Dr. Tom Porter. The first one was in 2008, so about 10-year period between them. But the last one is the one that you're going to use for clinical applications of ultrasound. And it's very nice, detailed, and we're going to go through some of these applications. One, as we talked about, improved endocardial border definition, delineation of which has implications in it. LV hypertrophy, at times you may not see it. We talk in the laboratory that you will miss often the degree of LV hypertrophy from the apical window because you're not in the axial resolution of ultrasound, and you will see some cases regarding that. Rescue of uninterpretable studies, particularly in instrumented patients in the ICU, surgical ICUs probably, and you will see some of these data. Stress echo is a expanded, if you will, indication because of the same issue. If I don't see as well, I'm not going to be able to interpret as much, but has not been developed particularly for stress echo. Doppler signal enhancement, particularly for aortic stenosis at times, if you can't see it very well from the non-enhanced view. And definition of structural abnormalities. If there is a thrombus in the apex, there are a lot of reverberations or artifacts that you're really not sure. Pseudoaneurysm tells you about communication from one chamber to another. So you think about it. Once the contrast goes to the left side, how do you want to use it? Right? So we're not using these agents, to just enhance things on the right side of the heart. We have saline contrast to be able to do that. Okay? And as we said, the appropriate use indication have not changed really over the years. Is if I see all my segments, I really don't need contrast, right? And if I don't see as well, and the less I see, the more impact the contrast will be. No question about it. And in our laboratory for many, many years, we have left that discretion to our sonographers because the order is usually an echocardiogram and use contrast if need be to enhance the images. And for you going to head laboratories and other places, communication between you, the physician, and the sonographer is very important because at times you may see a more utilization than probably should be, and then you have to kind of adjust, or less utilization in patients that you might want to see more. A big ventricle, question of a thrombus, or wall motion is not well seen. So gradually you'll get to a comfort zone where more and more appropriate use of contrast would be. I don't think there would be any controversy here from seeing this collage of the same patient that you tell me whether the ventricle is normal, yes or no, whatever you can say. And it brings me to a point where you, as future leaders of echocardiography, and you don't have to be a leader, you're going to be a utilizer of echocardiography. Unfortunately, and this is reality, is I could interpret this study very easily to say, technically difficult study, I cannot interpret ventricular function, or I can invent a number. This is not what you want, right? This is what quality is about. And I will say it out loud, that you will get an interpretation fee, be it technical or an interpretation fee. Have you done have you done any favor for this patient? No. You've used healthcare dollars to impact nothing. Actually, you impact negatively the bottom line. So the bottom line to you is, wherever you go, the impetus to use contrast is because of better quality of the studies that you're trying to do, more diagnostic accuracy, more impact on utilization, on management, on outcomes of patients. It's hard to measure, but people have done that already in the past, okay? So, yes, in a good laboratory, you would use contrast, and I think the sonographer has used the right decision, not a difficult one here, and then you could see that indeed the ventricle is really very good. So you go from a completely uninterpretable study to an interpretable study. Now remember one thing, that this interpretation is talking about ventricular size and function, global, regional. We're not talking about visualization of valvular heart disease, right? At times the right ventricle may or not be well as visualized, but actually you will hide valvular heart disease abnormalities if you're going to use contrast, because the ultrasound beam will be as reflective, right? So it is usually for ventricular function. Now, this is another case where not a difficult one to say ventricular function is depressed. And you could venture even say that the ventricular function is severely depressed because there is no descent of the base, and I have an inferior wall that's completely akinetic, the lateral wall is akinetic, I don't see the apex well, I don't see the anterior wall well, but I won't be too far from knowing that this individual is in trouble one way or another, right? But remember, whenever you see a ventricle like this, it is a harbinger for other issues, other problems. So this is the same patient with a contrast, right? So you could not suspect a thrombus in this patient. Management is very different. Prognosis would be very different on a mobile thrombus that you're seeing there in the apex, okay? So yes, ventricular function is down, heart failure, you name it, everything else, but I think it's important to see as much as you can for a better diagnostic accuracy. So don't be shy. If I have most of the diagnostics here, that if I'm not seeing the apex well, where most of these thrombi would reside, that I would use contrast in those situations. I think this is very important. Okay, take a look at this. I think most everybody would say, well, I have a very dynamic lateral wall. I can't tell about the septum. At end systole, most likely the heart is small and everything else. Beyond that, I see the atria, I see the right ventricle well. I don't see the left ventricle as well. You could decide not to use contrast. I would, okay, because I'm not really seeing too well. And actually, that's what you see. You see a hypertrophic cardiomyopathy with a major septum. That we talked about it before in previous conferences and talking to our fellows and faculty. Hypertrophy is underestimated, particularly from the apical window, particularly if you're not seeing well. So you gotta be very careful in those situations and use contrast appropriately. This is a case I always show because I interpret it as normal, and I got a call from our Dr. Neil Kleiman and said the EKG is very abnormal. Can you do something? This in the early days of contrast. No digital, this was digitized. I said, we have this new agent, contrast, let's see if we can use it and see what the situation is like. Because what I did is I interpolated wall motion, and in wall motion abnormality, actually it was an aneurysm, was very localized in the mid-anterolateral wall, not in the apex. So what my eye did is actually interpolated, wall motion here, although there was an aneurysm here that you couldn't see. 4-chamber was not as impressive. 2-chamber, actually, this was the area of abnormality, but most often, we use that. We interpolate the images and say that it's fine. So this tells you also about, things that could help you. I remember this case, I always show it because it was during a live demonstration when we did all these live demonstrations at the ACC in Bethesda. Patient comes overnight with this EKG and chest pain, gets admitted, and obviously it's not a normal EKG. You know what the differential is, ischemia and somebody with chest pain or something else. And you could take a look. This is the resting echocardiogram. There's a suspicion of an abnormality in the apex. I cannot tell, right? Perfect place to use contrast. There you go. There's an apical hypertrophy, right? So, I mean, that's your differential diagnosis when you see that such an EKG. If you see such an EKG and the interpretation of the echocardiogram is completely normal, you'd better knock on the door of the echo lab and said, let me see it, because it is at times very tricky to diagnose an apical hypertrophic cardiomyopathy. So you gotta be very careful about that. Okay, how about this? Take a look at this case here. All right, I'll tell you what my first interpretation is. I see, this is a two-chamber, I see an inferior akinesis, inferior base akinesis. There may be a suspicion of a hypokinesis in the apex, but I'm not sure. I know this is an abnormal echocardiogram. No question. Got it? Got it. And maybe a suspicion of an apical abnormality. If there is an apical abnormality, this patient has two vessel disease already, right? Okay, let's see what it looks like. Indeed, an apical abnormality. And on top of that, a thrombus in the apex. All right. Speaks to, I want to see so I can diagnose. And if I can't see it well, I cannot diagnose it to the best of my ability, right? So I think this is where appropriate use of contrast would be important. All right, take a look at this case. And tell me what you think. You can scream it out and I will say it. I'm sorry? Apical HCM, very important. That's a suspicion. You don't have a diagnosis, but that's a suspicion. And the suspicion is there may be crowding here, but there's a definite abnormality, which if you're an expert in interpreting wall motion, take a look at the epicardial motion of this heart on the outside of the ventricle. There's no motion. Remember, there's always motion of the epicardium, right? Usually comes in about 10%. And in this situation, it would be either akinesis of the apex or too much crowding, right? Meaning too much hypertrophy that you'll have anything there going on. And indeed, that's what you see. You see a nice apical hypertrophy, and actually you can see the the arterioles that are coming in and feeding. It's amazing, you know, really very nice depiction of it. Okay? So remember a few things. This is a case, the same case that you've seen, apical. Thrombus, what do you call this here? What do you call this from a technical point of view? This is attenuation, right? Attenuation. I have too much contrast. Up to here, I can't see below. Attenuation. What happens between here and here? Huh? They didn't wait that much. Yeah, exactly. So what, I mean, sonographer said, I'm not going to wait too long. I'm going to increase my mechanical index a little bit, you know, destroy some bubbles, right? Remember this hurricane heart. That's what you see here. Usually, ideally, you should wait, meaning second guess yourself from the first time that the injection was too fast. So next time when you inject, it shouldn't be as fast, right? So this is important. It's a nice summary of what we just described. Contrast, a patient with aortic stenosis, we usually don't use it as often, and we probably should not. If you have a good jet, you should not use it because you will enhance it and you'll increase the velocity. And if you want to push your luck to have more TAVR or SAVR, it's not a good thing, ladies and gentlemen. I know we tried in the past, should not. But here you go. And you would also wait a little bit for the intensity of contrast to come down, because early on you may enhance it. If it is too strong, you may enhance it and increase the velocity by about almost half a meter per second, which increases everything from velocity, gradients, and everything else, and decreases valve area. So this is a nice enhancement of that aortic stenosis jet, okay? And not over-enhanced either. Okay. How about, this is the potential impact of contrast echo. Outpatient, and this, I have not changed this from the first year I given this contrast, because we're talking about, more than 30 years ago. Outpatient, inpatient, ICU instrumentation, and stress echo. And these are probably similar in a way, the impact of them. And that has not changed. And the reason for it, in the outpatient, people are less instrumented, they're ambulatory, you have less lung disease, etc. So inpatient, more issues, right? And the more issues you have with instrumentation and breathing. This is an early study from Yankee many years ago, comparing fundamental harmonic plus contrast and TEE. And Dr. Young was initially in Corpus Christi. I don't know where he is now, and you could see it's almost 20 plus years ago. Contrast enhanced, similar to transesophageal echocardiography in the unit. So you will decrease utilization of transesophageal if the indication is assess ventricular function because somebody is not doing well, right? And actually you could measure volumes, you could measure many other things, very important. Contrast utilization in stress echo, right? It is not it's an off-label use, if you will, but it's a similar indication, meaning I want to enhance my endocardium to be able to see well. This is a normal contrast echo, as opposed to an individual who had bypass surgery, came in with recurrent chest pain. He was cath, I think, or some other evaluation, and the bypasses were open, but actually had developed more disease beyond the bypasses, and you could see the ischemic area and the posterior lateral wall there very nicely. Use it judiciously. This is one data that I will use that was done from here when Juan Carlos Plana was a fellow with us. Utilization is all over the place in the country. Who are the people who benefit? And we had a good series here, patients who underwent 2 dobutamine echoes, one with contrast and one without, randomized. And this was published almost 20 years ago. And interesting thing is when you use contrast, your visualization at rest and more importantly during stress is enhanced significantly and stays very good. The impact on your diagnostic accuracy is very high. If I don't see 2 segments or more, my diagnostic accuracy is low. And if I have just 1 to 2 segments, since most of the time, you're dealing with coronary disease, diagnostic accuracy is not affected. And if all the segments are visualized, you don't use contrast echo. And I think you should not use contrast echo if you have pristine images at rest. Another thing is for the sonographers and the nurses, you decide on contrast utilization before you do the stress portion. Meaning if you're struggling at rest, you're going to struggle more during stress. Use it if you're not seeing all the segment pristinely from the parasternal long, short, as well as the apical window, right? So make that utilization, because comparing contrast with contrast is the best way, as opposed to unenhanced versus enhanced when an individual has stress. This is a case from that series from Dr. Plana. Here you go. What are you going to interpret? You tell me if you don't use contrast. You tell me, okay? I can interpret here that in this 2-chamber view that the apex is not functioning well. I cannot tell ventricular function well. I cannot tell the extent. I can tell whether there's ischemia. This is dobutamine, 0, 5 mics, 10 mics, and 30 mics. I cannot. So what are you going to say as an interpreting physician? Okay? So you could tell that you're going to use contrast at baseline here because I'm not seeing well. And that's what you see with contrast. Let's see, stop it here. Just 1 second. One thing you could see is that at baseline, there was a wall motion abnormality. So this individual had a previous apical infarct. 2 is that at 30 mics of dobutamine, ventricle has enlarged at end systole, and the wall motion abnormality extended to more proximal all the way here. So this is ischemia as well as previous infarction in somebody who had a previous infarction and becomes diagnostic as opposed to non-diagnostic. Very important, right? So use it similar to what you would do for, resting images. Keep it in mind that your images, even with dobutamine, will become more challenging once you are on dobutamine, right? Another thing, not everything is positive with contrast, meaning that you may have different challenges. Be careful about shadowing and linear shadows. We don't have any pure linear structures inside the heart when you look at ventricular function and wall motion. See this linear shadow that you're seeing here? It has a straight line. You see it here, right? You see it here. The endocardium is actually behind it. So you gotta be very careful where your interpretation is. And this is a stress echo with 40 mics of dobutamine. Overall normal ventricular function, but you gotta be careful on the same patient, okay? Watch some of the shadowing that occurs because of the papillary muscle here. There is a linear shadow because of the, the distal anterior wall. But it's not interfering with my anterior wall interpretation. However, here, it is interfering with my interpretation. And actually, the endocardium is way down here. See where it is? There's a wall motion abnormality that has occurred at 10 mics already. So at times, it becomes more challenging, and be careful of where the endocardium is compared to, and most of the challenges are on the base. Because if there is any reflection, if there is any shadowing, it's going to affect the base much more. So be careful when you do that. And that's why, if you have a beautiful echo to start with, pristine echo, don't use contrast. Okay? So these are some of the general things that are important. Contrast improves endocardial definition at rest and more during stress. Translates into improved accuracy. Stress echo, probably utilization between 50 and 80% of stress echoes, depending on your baseline. If you're dealing with a majority of patients that are obese or smokers or something like that, it's going to be different versus the ones that are overall healthier conceivably, right? So keep that in mind when you do that. And for the sonographer, is you're going to have to probably find another window to optimize the window during your acquisition, and you'll notice that during the resting portion in addition to the stress portion. What's the impact on management? There are several studies in the literature. I'll take this one because it is very practical and it probably has the largest series that has been published, about more than 600, and this is from Dr. Kurt, who was initially an observer and now he's a physician in Turkey. And he did a great study with us here. Basically we had patients that were going to undergo in different scenarios a contrast echo, and we asked the question to the physician after interpreting the non-contrast one, as what would you do about this patient? And so they told us what they were going to do, and we gave them the final answer after we did, and what are the changes in your assessment and your management. So obviously, by definition, they had difficult studies, and these are the inpatients, MICU, SICU, outpatient, and total. After contrast, and in yellow is uninterpretable, in red is technically difficult. Most of them went into adequate interpretable studies, There's still some left over in the SICU where technically difficult and very few still completely uninterpretable, and that's life, right? The lowest utilization to start with and has impact is in the outpatient setting, right? And the highest and most difficult people are in the ICU, particularly in the SICU. What's the impact from a management point of view? Planned procedures, TE avoided, nuclear imaging avoided, and all these for ventricular function. The highest impact, obviously, is in the SICU and the MICU. What is the impact on medical management, medication changes? Remember, medication changes impact when technically difficult is the ventricle good or bad? So inotropes versus no inotropes. And anticoagulation, is there a thrombus? Yes, no. Yes or no? And this is what you see. Inpatient ward, MICU, SICU is the biggest impact. Hemodynamic drugs stopped because they were on, and they were hyperdynamic, versus anticoagulation stopped, versus hemodynamics drug started, anticoagulation started. And the biggest issue we have is at times you have reverberations in the apex and you can't tell whether this is a thrombus, yes or no. This is where the biggest impact is going to be. So this is overall impact management. Overall, I mean, the highest impact, again, in the SICU, about almost 70%, 60-some percent, very high on technically difficult patients to start with. And the lowest impact would be obviously in the outpatient setting because that's your least utilization, right? And as I said before, the more I don't see, the higher my impact is. If I don't see 12 segments out of the 14, 16, my impact's almost 100%. If there are 2 or 6 segments that I don't see, my impact is about 15% or so, and it makes sense in a way, right? Some case examples for you. Is this a thrombus or reverberation? Anybody? Thrombus. It looks like because the apex is abnormal, and it looks about right. There you go. The apex is, it's the right setting, right? But that's life. How about this? Trabeculation versus thrombus. Most likely trabeculation, I would say, right? Thrombus. But it's interesting, thrombus is not where you're seeing, these spikes of the trabeculations, right? It's what's behind the scene, the one that is right here, as opposed to the ones right here. How about this? Thrombus versus reverberation. Huh? Reverberation. Thrombus. Silent majority. You've been tricked enough. Okay, well, you've been tricked again. It's amazing, isn't it? It really is amazing. Of what you could be missing if you don't have a good, pristine echocardiogram, right? So use your judgment, use your judgment visualization, right? As to when to use, and we trust our sonographers. I think they do overall a great job because from the early days, the feedback of you overused it versus you underused it is much less nowadays, much less. And don't feel, right? If you feel contrast will change your diagnosis, it's okay to call the sonographer and say, if the patient's still here, whatever it is, said, do you mind doing the contrast? Because we're looking for this and this and this, right? As opposed to leaving it, I wish we could, right? So I think you should do that. This is in relation to some few cases that with anaphylactoid-like reaction, you probably heard about it. And I'll share with you some of the data that we know. Contrast agents are used nowadays in almost 7% of all echocardiograms in this country. If I given this lecture 10 years ago, it was close to 1%. It may still be underutilized depending on where the pockets are. Yeah. There is rarely an overutilization unless people are mandating to use contrast in every ICU individual or in every stress echo, okay? But I think you saw that utilization really depends on the setting and the images that you get, outpatients versus inpatient versus instrumented, etc. Anaphylactoid reactions, which is anaphylaxis-like, right, reactions, are believed due to interaction between the liposomal shell, right, and the complement system, estimated to occur rarely, 1 in 10,000, 1 in 15,000 cases, and may occur without previous exposure. Which tells you and tells us, obviously we're prepared for this in case it happens, is that it is a drug, all right? It's not just contrast, and contrast that is used also in the cath lab and whatever it is, nuclear techniques, everything. All of them are drugs, and you can have an allergic reaction to them, you can have an anaphylactoid reaction, you can have back pain, you can have whatever it is, right? So you have to be equipped in those rare emergencies that happen. Type 1 hypersensitivity has also been proposed as a mechanism explaining severe allergic reactions. And this could be, from the, component of that shell to stabilize the shell, which is PEG or polyethylene glycol. The only contraindication now we have to the use of ultrasound agents is hypersensitivity to the drug. So obviously if you used it one time and you're not going to use it with its hypersensitivity. But in response to a few reports, there is a clarification to the existing contraindications for Definity and Lumason, not Optison, because remember the shell composition is different, to specify that administration of these two agents is contraindicated in patients with a known hypersensitivity to PEG, to the polyethylene glycol, which can be in some laxatives, etc. There is some recent data. Actually, data is still online prior to publication that I just discovered yesterday. And this is from Gonzalez et al. In the American Journal of Cardiology, and that's actually coming out this month. And they did a comparative safety of ultrasound agents, systematic review in addition to a network, analysis from, you're talking about thousands of studies and millions of exposure. It's non-significant difference between Optison, Lumason, Optison and Definity, Optison and no contrast. You could see that. A little tendency to less major effects, and remember this is 1 in 10,000, 1 in 15,000, and part of the reason you cannot come up with any strong recommendation is the rarity of such an event. Okay, so for such an event, obviously you have to be prepared in the hospital or in the clinic or wherever you are. There was with that an editorial that I would encourage you also to read. I think you should read both of them, entitled Illuminating the Safety of Ultrasound Contrast Agents by obviously leaders in the field, saying that obviously because of the rarity and statistically you can do all these kind of things, we cannot say for sure that there is a difference between these agents. These agents are important to use because when you look at safety, what is available, you have to take a look at not only safety of the agent and also the implications of what you're seeing and the implications of that diagnostics as opposed to an alternative diagnostic modality that you might have seen. So I think it's important to keep that in mind. These are medications that you have to be careful about and have all the precautions just in case the rarity of that event of 1 in 10, 1 in 15,000 occurs, that you should be prepared for. And last is myocardial perfusion. Just a few things for you since we're not using it. You see contrast in the ventricle and the atrium, right? And remember, ultimately, they're going to go through the arterioles and the capillaries. Interestingly enough, the velocity in the blood, in the cavity and in the aorta is the velocity of blood. And you see that usually in centimeters per second, et cetera, that you know. But you need to know that at the capillary level, the velocity is very low. is no longer pulsatile flow. It's almost static flow in the capillaries and move, 1 to 2 millimeters, very slow motion per second. Okay. So if we're talking about slow motion of the red cells, blood, it's inclusive of contrast, and that's why. If you don't do anything to the usual things that you do to image contrast, you're not going to see perfusion, because there is quite a bit of exposure in those capillaries to the ultrasound beam. So you're destroying the contrast in the capillaries, so you're not seeing perfusion per se, unless you do something different. You understand? Because it is so slow, bombarded by ultrasound, you're not going to see perfusion distinctly. Here you go. So if this is regular imaging, continuous imaging, versus intermittent imaging. So I stop destroying, wait for it to replenish, image again, and you could see that I have much more contrast in the myocardium compared to the right side. And actually, Sanjeev Kaul and Jonathan Lindner, Kevin Way, actually they were at UVA when they were there, proposed this intermittent imaging of contrast. You can destroy and then image intermittently and, basically measure blood flow, how much blood there is and velocity of blood in the myocardium. Technically demanding, obviously. Another way to do it is I decrease my mechanical index significantly, so I preserve as much as I can of this contrast there for me to be able to see it. Another popularized one is I use low mechanical index for imaging, but I hit it with just a burst of high mechanical index. So here you go. And this high mechanical index, after what you see here, is destroyed, and then gradually it replenishes over time. So in a way, you can see myocardial perfusion there. And so this is one of our patients. We did a lot of studies in the past regarding that. This is I destroyed. Then I'm look at perfusion in this individual with an apical wall motion abnormality. Notice what happens during diperdomol, where you increase myocardial blood flow. Intensity, even in the apex, is down of contrast. And I'm going to hit it with a high mechanical index and watch reperfusion in there. You could see it reperfused, but not in this area here. Notice that's beautiful, but also if you want to be critical, if I take a look at the lateral wall, we're here posteriorly, it doesn't look like it's perfused well, yet there's wall motion in it, right? So problems usually in the bases of the heart with contrast, a lot of research went into that, but we don't have a clinical indication for contrast, although many studies were done in the past, and you don't see as many studies nowadays. Yes, you could use it for large vessels to look at vasovasorum and other things, but usually this is all at this time still educational or research. So in conclusion, few things. One, we spent quite a bit on appropriate use and also the technicality of it. This is very important. And I think I'm glad that I see that utilization is almost 7% in the country. And it has to be appropriate utilization of where you need it. And the impact is amazing from a clinical point of view. We need to be optimized for 3D and strain, where we're not there yet. Perfusion, technically demanding, not approved. And it's not as competitive with the other modalities that we have nowadays. You have PET nowadays, right? And you have, CMR, but certainly PET is the big winner from a perfusion point of view. It's great for research, and why? Because you could do multiple manipulation and look at perfusion multiple, so you're not stuck with a radioactive material or other things. It's amazing actually for research. Role in therapeutics, gene delivery coded to the microbubble itself, and you can destroy it at the level of, be it pancreatic cancer or other things in cancer. Thrombolysis, exploration and vascular imaging, vasovasorum imaging, I think these are all exciting ones. But I really want to emphasize the appropriate and good technical utilization, because this is an available methodology that is only driven by quality of a laboratory, be it the sonographers, the physicians in the laboratory, and I think should be demanded in every laboratory with appropriate use in patients where it could help diagnostics and certainly outcomes point of view. Thank you very much for your attention. Questions? Any questions? Any questions? Hearing none. Thank you very much. Happy New Year.